Welcome to beautiful Copenhagen, Denmark's great capital city. This year, Vital Options International took on its 6th year, providing on-site coverage of this signature gathering, the essential ESMO Congress. The European Society of Medical Oncology combined the efforts of the most important European oncology professionals with the aim of improving prevention, diagnosis, treatment, and care of cancer patients. Well, the timing could not have been better. From new therapies and integrated cutting-edge technologies to the enduring role of the patient advocacy organizations, this ESMO gathering represented the finest that the oncology community has to offer.
I'm Alfonso from Myeloma Patients Europe. That's okay, Bettina. So I would really like to raise a question to the clinicians, to the HCPs here in the room. I have a good bunch of friends from my age who decided to study medicine when they were 17, 18 years old. They were thinking a lot about helping people, saving lives, offering the best to the patient. After going through the university, they were more focused on treating diseases, and every time they have a failure, they have someone simply didn't make it, they consider this like a fiasco. And at the end of life of certain patients, basically they couldn't just cure them. I have heard that the sentence that Cathy mentioned, all we can offer is palliative care. I was thinking whether maybe training at universities of medicine is doing something wrong, because maybe they should make students understand that this is not only about curing or treating diseases, this is more like an holistic approach of caring a person. So what is your point with that? Do you think we are probably making something bad when we are training doctors?
Let's go to, I'll come to you in just one second. I'd like Jennifer, can you respond to that? Because we're asking about the training of medical professionals, and maybe this is the key.
So, sorry, too close. So I would argue it is an education issue, but in response to the previous question, patients and clinicians are smart. No matter what you call it, they're going to figure out what you're talking about. And there's nothing inherently negative in the word palliative. And if we start calling it supportive care, instead, the uneducated doctor is going to say, all we have left for you is supportive care. And I would argue that, for example, at our institution, where we've done early palliative care research and clinical practices for 2 decades, we understand the definition, and our clinicians don't have any difficulty talking to patients about this. In fact, one of the #1 reasons why our clinicians don't enroll patients on our current palliative care studies is because they say the patient needs urgent palliative care. They can't participate in a study. And when our clinicians do offer our patient studies, the #1 reason why our patients refuse is because they say palliative care sounds so good, they want it now. So I think it's totally true. So I think if you educate your clinicians, because patients rely on their doctors and nurses. That's who they listen to. And so their doctors and nurses and social workers and chaplains and other clinicians, they have to be able to explain to patients what this is. And if you explain it, as Nathan says, everybody wants it. So I don't think we need to change the name. I just think we all need to communicate more effectively with our colleagues and certainly with our patients and families.
Thank you. Liz Toy, clinical oncologist in the UK. It's partly in response to both questions and maybe being a little controversial. I would argue that nothing in the definition of palliative care is actually any different to what ordinary care should be about. Within the UK, we are very fortunate. We have a very established specialty of specialist palliative care. But we should be educating all our, not just our trainee doctors, but our nurses to be assessing not just physical and psychological symptoms, but also cultural and spiritual. And certainly that's very much a focus in my own trust, where we're rolling out a program called Opening the Spiritual Gate, where everybody, whether they're a porter, a hospital nurse, etc., is expected to screen and then refer on, maybe to specialist palliative care, it may be to the chaplaincy. So I think specialist palliative care is about complex symptomatology. Everything within that definition is something that all medical professionals should be being trained to screen for, recognise, and then if they don't possess the skills themselves to deal with it, then to refer on, escalate upwards to somebody who can.
So this is Sarper from Myeloma Patients Europe and Lymphoma Coalition as an advocate. But I'm on the other side of the table as a physician, as a transplant coordinator, so I can see both sides. I mean, we're stuck with the term palliative care, but this is not the only word. So just changing the word will not change anything. So it's just that when you don't understand something, you use a dictionary or a glossary. And in this case, it's the patient advocates who needs to be empowered to get patients understood by the physicians and vice versa. Thank you.
I think that's a very good point. I mean, patient advocates do similar things for other areas of treatment, so why not also provide better information to our patients to help support this universal idea of palliative care? Nathan, did you have something to add to this particular comment?
The term palliative care came about because there was too much stigma associated with the term hospice care historically, and so this can become a fairly endless process. And there are centres that have changed their name to supportive care, essentially to try to overcome barriers associated with stigma. And I think that the issue is partly one of branding. But I think that one of the issues which has not been touched upon is also a structure of organisational structure, because if one wants to access palliative care, it's palliative care is the next floor upstairs or over there in the other department. We can set up an appointment for you. It emphasises the fact that this is a different part of the treatment paradigm, yes. And I think that hospitals, I mean, we gave a lot of thought when we developed our service as to where to place palliative care, and so
where to physically place it.
Yeah. So we are physically placed inside the Oncology Day Hospital because we asked the question: where do most cancer patients with symptoms and with other problems? Where's their point of contact with the hospital? And we said, well, that's what we need to be part of that. We need to be a presence there all the time. And so by being part of the physically part of the service, it sends the message that this is just part of the global care package. And I think that there's a lesson to be learned, I think, for hospitals developing services in terms of organisational structure and physical structure, which impacts on overcoming some of these barriers.
Strasse from Switzerland, chairing the Designated Center Working Group. I would expand on what you said, Nathan, and say we should change organizational structure, that palliative care happens inside the routine oncologist professional. And in addition, there are palliative care specialists who amend this professional. Can I quote you? This is my colleague, specialist for sarcoma. He does not palliative care specialty, but he does a lot of palliative intervention in his routine care. So in our structure, he has in his heart already palliative interventions. In addition, we work very close. So my question to you advocates is, do you want that your oncologists say, I will give you palliative care and anti-cancer treatment, and I have also specialists which help me if it gets too much complex?
Changing a name will not change anything. There are other terms we use and which patients don't like. What do you think about you have cancer? Is that a stigma? Does any patient like to be called you are a cancer patient now? And why is this the oncology conference? They took already another term. If you go to the department and in the hospital, you have to go to the wing. Cancer or the oncology department? They try to change the name, but in the end you get the same. Therefore, and I'm fortunate to come from a country, Belgium, and the Netherlands are the same, where palliative care is an item that is known. It is a responsibility of all of us to make sure that patients know what the meaning is. It is not end of life, but end of life is part of it. We have to explain that. And there is even in some countries the possibility to make a choice regarding the end of life. Legally protected and within very strict limits. That's equally, this can be discussed, not for everyone, we appreciate that. But at least in Belgium and Netherlands we know that there is a continuum when you enter into a very serious disease. When you have a cold, you don't need all this.
Okay. I think this last half an hour or so has been very interesting. We've talked, I think we pretty much all agree, and stop me if I'm wrong, that there's still some debate, quite a lot of debate about terminology and what we call this and, you know, how we describe it to patients. But I think one thing we all agree on is that this has to be a multidisciplinary approach. It has to encompass actually not just the patient, but the whole family sometimes. And this is not always provided.